Hey, everybody.
Hey, everybody, and welcome to Care Concierge with Carepatrol, where education is the heart of everything that we do. Carepatrol is a senior or aging care placement specialist, and we guide and advocate for our clients' best interest with providers and caregivers and anyone that may be in their lives with whom we can have some sort of interaction. One of our key employees, in fact, our Chief Clinical Officer, C.W. Merritt, an RN of over 30 years, is going to be presenting for us today on a topic that was suggested by a former attendee to Care Concierge. I have, if you can see the screen, you can see I'm showing our YouTube channel. And this is, I've got the address typed into the chat room for you. And you can go there and watch quite a number of past CEUs, all of which are recorded, and get additional credit if you need it in a pinch. So just want to make you aware of that. We also, while you're there, have some videos you may want to share with clients who just answer questions about some things that may be of interest when you're looking at getting care for someone in your orbit. We appreciate you being here with us today. Spring has sprung. It is gorgeous and beautiful. It's warm. And I'm sorry you all are indoors with us right now, but I do appreciate that you are, because it says that you are clinicians who wish to know more to better serve your patient population. And those are the people we love to work with most. Care Concierge is accredited by the State Board of Nursing for Alabama, as well as the State Board of Social Work. Generally, these credits are interchangeable between states. And we, in order to present this for social workers as being a live or face-to-face CEU, we have a password protection system for the evaluation. You must do the evaluation in order to receive credit for this hour. And within 24 hours, you will receive, after this presentation, you will receive both your certificate and this presentation for your future use. And so I will now change screens. We'll just move along and get to our presentation for the day. And I'll introduce for you our Chief Clinical Officer. Now, some of you may know CW and some of you may not, but I would say that, you know, in my experience, he is perhaps one of the most intelligent and even intellectual persons I know, regardless of his, you know, training. And so I know that whenever CW does something, he puts his all into it. That's true if you refer a client to us, for which we're eternally grateful, or if you are, you know, sitting in today. So CW, I will turn it over to you today. I think I've covered everything in terms of evaluation, et cetera. I do want to say to y'all, we do appreciate and want your discussion and your ideas. We want this to be interactive, because I believe that when others hear your voice in addition to ours, it is a much more rewarding experience. So for that reason, we'd love for you to participate. However, technical difficulties lately with people, you know, unmuting their mics without knowing has, you know, caused a lot of our attendees to say, you know, you need to stop doing this. So we're now going to discuss things through the chat room. However, if you want to say something, just let me know in the chat room, which I'll monitor, and we'll bring it up and I'll unmute you and we can have a robust, I hope, discussion. So now, without further ado, and happy Friday, Mr. Bryan and Ms. Chestnut and everyone. And happy Friday to you, CW. I look forward to this. Thank you so much for doing it.
Yes, sir. Thank you, Sean. Happy Friday, everybody. I guess you could say I'm at the beach, at least in my mind. And, as we get started here, you may see my ADD acting up because all of a sudden there's two giant dogs running around right outside my little office window here. So, but today we're talking about reading basic labs, understanding basic labs. And it's a very useful topic. I appreciate it having been requested. The first challenge I had when I began to prepare the presentation is that we have an hour, 50 minutes. And I think we could spend 50 days on this particular topic by the time you look at all the labs that we encounter, particularly in the acute care environment, and all the things that we do with them. We could go on for days and hours. So for the purposes of this course, you're going to find that a couple places I've sort of simplified. For one thing, you will see that I used when I first drew up the basic metabolic panel and comprehensive metabolic panel, I intentionally focused on one lab because what I wanted us to do was go through the process, understand what that lab meant, how it would be used from beginning to end, from reading the order to begin with, to drawing it, sending it to the lab, and then dealing with the results and the treatment that come of it. So that I wanted to make sure everybody kind of got that one piece. So rather than trying to go down to every individual lab value on that one, I took a little bit of a different approach. So here we go. Okay, wait a minute, Sean, I need to back up a slide. I think you're ahead of me. I'm sorry, guys. I'm still learning about technology. Okay, there we go. So, I wanted to talk about this anyway, because there's problems associated with labs. And one of the things I like to do is, come up with problem solutions as we work along. It's kind of a two birds for one stone thing. We learn a lot and we hopefully engender some solutions in the process. There's a lot that goes on with labs that make them important to discuss. There are some issues. For example, the number one area for lab errors is not at the point of the test or the analysis as it's referred to, but rather before and after the test occurs by simple things like mishandled specimens, mislabeled specimens, wrong patient, right tube, etc. And so I think, along the way here, hopefully we'll do some things that will help us meet the goal of improving our practice when dealing with labs, understanding them better, and thusly using them to ensure better patient care, better outcomes, and a little less frustration amongst our clinical staff. All right. So today, when we finish our presentation today, I hope that we can say at least 3 different diagnoses associated with different specific labs. Although a lab may not be, any individual lab probably will not render a diagnosis, it's good to know what conditions are associated with, why we would draw those labs based on the condition that we know about, the history, the patient's presentation, and what diagnosis we might either derive from it or for which they may be ordered. We want to know 2 or 3 good abnormal labs, something that you're going to encounter all the time that you'll be able to spot right away and know when it's abnormal. And we want to talk about 3 different errors that occur in handling specimens and labeling specimens. What does learning more about basic labs, how does it matter? What does it mean to y'all? What challenges do you have with basic labs? And why are we going to talk about this? If y'all want to unmute and give me some feedback, I welcome the feedback. This is intended to be an interactive class when possible, and learning is experiential. I think people learn more and more effectively when they're sharing. So if you have anything to share, Sean can unmute you, or you can turn your mic off and pipe in at will.
Yeah, now if you do, so Darla Dean says, understanding labs helps the patient make better informed decisions. That's interesting.
That is a very good point. It dovetails really well with one of the purposes to talk about this, and that is to have a better understanding ourselves so that when we're educating our patients, we can do so more effectively and answer their questions more effectively. So indeed, that is one of the purposes in talking about this. Thank you very much for that comment. Okay, so I guess it's probably no surprise to most of us that lab tests are just evolving all the time. I hear of a new lab, seems like every month almost. So that's an important reason to review them so that we can keep up with it. It was also, particularly as nurses, when we're encountering new procedures, new tests, new labs, it's really easy for us to be so caught up in the day and the activities and take care of our other patients that we're learning that lab, its meaning, how to administer the test, whatever, we're learning on the fly. So anything we can do to learn in advance or have time to really process the information and put it to good use is a good thing. 160,000 adverse patient events occur each year in the U.S. because of patient specimen identification errors and mishandling. 11% of all transfusion deaths occur as a result of the phlebotomist not properly labeling patient's blood. And then, the overall cost of medical intervention was $282 billion in 2006. And, more effectively running labs, not wasting specimens, getting better results. Those are going to help introduce some cost savings along the way too. Okay, next, Sean. Thank you. So I think you skipped one. Okay, yeah, I wanted to take just a second and talk about, there's a million different kinds of tests out there for everything you can imagine. If there's a body fluid or body tissue, there is probably a test for it, either already in existence or being developed. So, what do we test in the lab? We test tissue samples. Maybe a good example of that will be a tissue that's taken for breast biopsy to identify if there's cancer there, if so, what type and at what stage. Urine is a pretty frequently tested thing, and it's a good buddy to the blood test because it reveals a lot for cheap and easy. It's not invasive. But we look at a specific, just for example, how the labs fit together when they look at a BMP and look at creatinine, BUN, etc., and then look at a hematocrit hemoglobin, and together get a little bit of an idea about hydration status. And then we look at specific gravity in the urine. Boom, we have a lot of information about that one topic with those three things. Feces, ova and parasite, looking for blood in feces. And one of the things I put a little note in here, this is not fully practical yet, but it's fascinating to me. I put in there the microbiome testing. I don't know how many of you have checked out the Human Microbiome Project. If you have not, it's coming to a neighborhood near you soon in the way of new tests and new interventions. So there are already some microbiome tests out there available for private purchase. They're just not available yet as approved by FDA, and they test a myriad of things, including the DNA of bacteria in your gut. It gives the researchers and doctors some clue about what disorders you may have, because now, rather than looking at the bacteria or the waste products of the bacteria, byproducts, now the researchers and doctors can look directly at the DNA of the bacteria itself and learn a lot about our overall condition. So it's fascinating. I won't go further into that because it's not very practical, but if you haven't checked it out, you should. Blood, arterial, and venous. And this includes tests of serum, plasma, and cellular products. Serum is what we actually are testing most often in the blood work world, and blood work is the thing we do the most of when it comes to testing these days. So it's important to kind of get a little bit of an idea that serum and plasma and cells are the three primary components of blood, and all three of them get tested. For example, with an RBC, with a WBC, we're going to be looking at an RBC2 counting the number, literally, of cells in any given volume. So we're testing the cellular components there. Plasma is the liquid volume of fluid that has not clotted. So in other words, it's the actual untouched, pure liquid part of blood. And we test it often too. And then naturally there is the serum. It's important to kind of have an idea about which type of test you're performing. For example, if we're going to do plasma-based or cell count-based labs, the tubes that they're stored in probably need to contain EDTA or potassium EDTA, which basically is a preservative and an anticoagulant. So anything we're testing plasma with is probably going to use a tube with a preservative and or an anticoagulant in it. Conversely, serum, they're going to put it in a tube and spin it down. What's used to be commonly known, I found some references to it, although I don't see it described as such, a serum separator tube, the old red tiger top with a little goo in the bottom. It's like Vaseline or something. Those are what we use to separate the serum from the other blood products. Cerebrospinal fluid offers a lot of information when tested. We may look at everything, from an example of how labs being collected from different sites yield different sets of information. One of the things we're going to get from a cerebrospinal fluid collection, TAP, if you will, is we're going to get an opening pressure. So an opening pressure is going to tell us a lot in addition to the glucose and the cells and the proteins, et cetera, that are in the cerebrospinal fluid. It's another good example of how all the labs work together. That one little detail is going to add to the big picture for the doctor to order treatments on. Sputum goes without saying. Another exciting area that's moving along and probably coming faster and faster is the exhale or breath tests. CO2 monitoring made a big change in how patients are cared for, particularly in the intensive care unit. Then you have things such as the H. pylori test, which can be done by breathing, the nitric oxide test to determine the effectiveness of asthma treatments, hydrogen measurements to diagnose lactose intolerance. These are things that can be done by simply blowing into a bag. So that's a great advancement. Okay, Sean, next. So look at the term blood work. See, I've got it sort of in quotations there. So we're doing a high volume of blood work in the United States all day, every day. Doctors rely on it. Maybe sometimes are overly rely on it, according to some of the information I've picked up on in my research. But the results of blood tests and how they are applied have a huge implication to our care. As well as the fact that we do them just about more often than anything else. I wanted to focus on blood work more than other types of labs today. Okay, Sean. So let's look at this word normal that I've got under quotes at the top of this slide, entitled Reading Basic Labs Reference Values. Normal values, reference values, they're kind of used interchangeably. They have some slightly different meanings, but essentially your reference value is going to be your normal value, and or these present you the scale of results by which treatment decisions were made. For example, in the case of a cholesterol level or a lipid profile. We're going to look at those results and we're going to know right away how aggressive the doctor's going to be with dietary management, exercise, medications, how many medications, what kinds. So it's a useful measure to have those normal values. Some values are reported as simply a yes or no, or a positive or a negative. Others come in a range. For example, a white count or a red count, there's an acceptable range for those. Or potassium acceptable range is 3.6 to 5.2, and that's pretty consistent with most labs. For the lab values do vary. What is known as reference values, well, would refer to them, meaning whatever that particular lab's quote normals are or ranges are. They vary from institution to institution and lab to lab. So it's important to know what your institution's lab reference values are. And for the purposes of this conversation, I think I used Cleveland Clinic once, but most everything else about the labs and the values came from the Mayo Clinic laboratory. Let's see. The one thing to know about this is that the lab, and you're going to hear me emphasize this one way or another along the way because it's critical. No one lab reference value is going to provide you. I realize there are some rare exceptions, but as a rule, no one lab value is going to provide you with a diagnosis. It all needs to be put together to produce a diagnosis. So that's why I asked the question, can we rely on labs alone? No, we cannot. We need to have all the information from the clinical. In order to make labs make sense and get the most use of them, we need to know what's going on with the patient from the point of presentation to the clinical findings to the other labs that are being ordered. And then when we put all of that together, we can create a diagnostic picture. So what happens is doctors and healthcare providers use those reference values to determine what they believe to be the values that a healthy person would have, as opposed to someone with the disease. And then from there, when they see those values out of range, They could then begin to order other tests or formulate diagnoses or clinical syndrome scenarios as they go along. Next, Sean. Thank you, sir. So I used here, if you look on the right side of the screen, I use here intentionally the oxygen saturation level and how it relates to the CBC. And it really even to the metabolic profile. So you look at the oxygen saturation level on a patient in the ER, it looks normal, everything's fine. But then you look at the patient, he spells the ghost, he's still feeling like he's short of breath, but he's got a good oxygen, good saturation level. But if all the hemoglobin is saturated, that's great. But is it carrying it right? The oxygen right? Is it delivering it right? Is there a sufficient volume of hemoglobin in the red cells to carry the oxygen that we need to get to the tissues to provide adequate oxygenation and perfusion? So just looking at a SAT level alone is another example of one that may not tell you much, except for the fact that the patient doesn't have enough oxygen in their blood. And it may not even tell you that. So in order to get to the bottom what a saturation level means, you may need to look at the CBC, the hematocrit, the MCV, some of these other tests that have to do with measuring available hemoglobin. You also may need to look at the metabolic profile or additional tests to look at things like total iron binding capacity, ferritin levels. These are things that all affect oxygen, how the oxygen molecules are carried on the red blood cell and delivered to the lungs and back. All right, next. Thanks, Sean. Okay, so some things that, like I mentioned earlier, are going to be a yes or a no, or positive or negative. But some things occur on a range, not necessarily to say this is a normal range, but to say these are ranges we know we need in order to effectively implement and gauge the assess rather the effectiveness of any given treatment. Anyway, that's enough of that. I just want y'all to kind of get the picture that the CBC, the metabolic profile, and the saturation level all would need to come together to produce an accurate answer for us. So you could have the same example here. You could have a normal SAT and still not know that the molecules are being carried to the periphery as we need them to. Iron binding capacity, ferritin levels, I mentioned that. Okay, next, Sean. Thanks, sir. I put this slide in here and I put this little goofy thing on the side where it says the oxygen bone is connected to the hemoglobin bone. And then I've got the slide to illustrate just how much interaction there is between any given cell type, the morphology or shape of the cells, the nature, the quality of the hemoglobin that is on board, and all those things get measured in the CBC. In order to make further sense of it, the doctor may also need a chest X-ray or a CT scan to put together with those other labs, other diagnostic findings to produce a good diagnosis and treatment plan. So since we're working with blood mostly for the purpose of this conversation, I want to just kind of point out again that the fact that blood work is used regularly is a little bit of a misnomer. It is important to know, for example, if you look when we get to the slide that shows the metabolic profile, you'll see that beside each test at the end of it has an S at the end of it. That means it's a serum test, which means you have some idea before you even look at the lab's policy or whatever, you have some idea already what kind of tube you're going to need to draw that. If in doubt, and it's a serum test, draw that tiger top tube, that red and gray top tube, and send it. There are other tubes that may be applicable for specialized testing in that arena, but that's a pretty good bet, just knowing it's a serum test. Plasma, is going to have some, it's going to need anticoagulant and preservative in order to keep the blood from clotting and to be able to extract the actual plasma from the solids as opposed to extracting the serum from the solids. Okay, next. Thank you. So what do you guys think are the most common blood tests? I was kind of surprised a little bit at this when I looked it up, but what do you guys, what y'all's guess? Yep. Somebody
CBC.
see. Bailey Wright.
She read ahead.
Yeah, She did. But she said the CBC is one of the most common blood tests, and that is indeed an accurate answer. What else you guys think good lot? Okay, so here we go. Here's the top 5. You go ahead, Sean. Lipids. Thank you, Bailey Wright. Thank you very much. We're actually going to take a brief look at the lipid panel. It is indeed one of the most commonly ordered and performed tests. So the CBC is the most common of all the blood tests, according to Hallel Labs and some other references I looked at. There are hundreds of types of tests, but the 5 that won in terms of most often ordered in the United States are the CBC, the cholesterol panel, the metabolic profile, the thyroid function, and the A1C. And that is the best I could gather from research in actual order of frequency. Next, Sean. Thank you, sir. The reason you see I got Elvis over here because the CBC is the Elvis of blood work. And the reason is that it doesn't provide much in a diagnostic sense, but for the doctors, when they look at the CBC, they get a lot of information about the general health and maybe some idea about what other diagnoses may be impacting the results of the CBC. Let's see. It looks at overall health. It looks at things like anemia, indications of infection, what the blood's ability to carry oxygen is, what the blood's ability to return back CO2 is, and that kind of thing. It even yields a little bit about clotting because it includes a platelet count and a mean platelet volume. So it's very useful as a general guide that can be used with other lab results. Okay, Sean. Okay, on the CBC, what we measure on there is the red blood cells, is kind of get a gauge of oxygen carrying capability. White blood cells, they have to do with infection, immune response, allergic response, and sometimes we get some clues about things like a potential dysplasia or cancer by looking at the white cells. Not only the count, but the morphology, the shape, and the fragility of the white cells. And one good example of how hemoglobin and cell shape and all that comes together to impact oxygenation is a sickle cell patient. You think about when we have a sickle cell patient comes in crisis, what do? We hydrate the heck out of them. Probably gonna give them some antibiotics and give them some supplemental O2. That's because the sickle cells are probably being destroyed as they go through I just make it simple, narrow spots in the bloodstream. So when those cells are destroyed, it's going to increase some other values like the ALT and some other things on the liver studies, as well as it may give us some ideas about what specific type of development how the bones are producing white cells and red cells. So it's important to know that the doctors or other qualified physician or clinician needs to be the decision about what gets measured and what it means, and others don't need to be speculating. Now, that's strictly the domain of the doctor and or the other clinicians, the NPs and the PAs. Next. So in addition to the white count, red count, we got the hematocrit, hemoglobin, the mean corpuscular volume, the mean corpuscular hemoglobin, the red cell distribution or RDW, red cell distribution width, and the platelet mean volume and the platelet count. A CBC can be run with or without a diff, as it's often referred to, which is short for differential. And what we're differentiating is the white cells when the differentiation is ordered on that. And this gives us some idea about which cells are involved in what pathology and to what extent. Okay, next, Sean. The CBC is not a definitive test. It's not intended to be a definitive test. And it's also important when we look at this, the CBC, other things, and you're going to see I focus on the potassium later on. It's a really good example. It's important to know what the trends are. and other things that may affect the outcome of the test itself. For example, if a specimen is roughly handled or is put in the wrong tube and it clots, the RBC may not provide a whole bunch of anything useful. And indeed, the test, the metabolic profile may be quite misleading because the potassium is going to be high if it's measured from that tube. So, cell destruction, improper tube usage, improper labeling results in errors and useful information that's no longer useful to us because of that. Next, Sean. Okay, what do abnormal CBC values tell us? Anybody got any additions to that? All right, so the CBC is used to aid in the treatment and diagnosis of a bunch of different things. Here are some things that we use the CBC to get clues about what's going on with the patient. So on the CBC, we can see indicators of infection. We can see indicators of bleeding, immune function, hydration, oxygenation, allergies, and inflammation, and really others. But those are primary things that we get from the CBC as a whole. Okay, Sean, thanks, sir. So this is kind of a little bit of redundancy, but I left it in there because, it talks about the white cells fighting infection. That's what we're hoping that the white cells are doing as we're measuring them. The hemoglobin and the red cells, we're looking to see how well they're carrying oxygen and CO2 back and forth. The hematocrit is the amount of red blood cells in the blood. That's not a completely accurate description, but it gets to the point. With the hematocrit, we're going to spin that blood and get it down to where we have basically the cells all clumped together, and we can tell things about the number of cells as well as the ratio and proportion of fluid, red cells, etc. Thanks, Sean. And I mentioned this before, but it's important to remember when you're looking at a white count, particularly on a really sick acute care patient, that high WBC or leukocyte counts can indicate infection, immune function, medications, other disease processes, and perhaps more importantly, dysplasias. A leukemia, for example, might pop up. First indicators may be seen in the WBC that we may have to rule that out. All right, next, Sean. The mean corpuscular volume talks about the measurement of the average size of your red cells, and the mean corpuscular hemoglobin is a kissing cousin to that. And essentially what it's saying is that when red blood cells are exposed to stress, when they are when they're dying, when they're, whatever is causing them to be, quote, stressed, they change shape and size. They may get thin and weak. They may pop more quickly. They're going to age at a different rate. So when we look at these cells and how they relate to the fluids in the blood, we get a really pretty good idea about those things. Pardon me, let me turn my phone off. Baby is going off the hook. I thought I turned it off. Pardon the disruption. Thank you. Okay, the white cells each have a specific function. And that's why the differential is done. And you can see on this slide where we have some of the cells visible that we're going to count. Okay, next, Sean. Here's the normal values for the white count. And I'm not going to linger too long on them. Probably some good things really to know and have on the tip of your mind is the white blood cell count, the platelet count, and the hematocrit and hemoglobin. In terms of practical usage, those are things I see used most commonly all day, every day. And I'm looking at the bottom of this page. I meant to look this up. Can anybody tell me what a femtoliter is? If you look at the MPV, it's expressed in terms of volume per femtoliter. On a quick look, I had trouble finding that. If anybody has the information on that, I'm open. Same for the MCV, it's expressed in femtoliters. The RDW is probably something to have a little bit of an idea about when you're looking at results, because it does yield a lot of information about what's going on with the red cells and the red cell health and function. The red cells are, on average, should be between 6 and 8 micrometers in diameter, and they can be smaller or larger depending on what kind of situation is happening. Common metric unit of volume. Thank you, Darla Dean. I think I understood that, but not sure exactly how much that is. It's not much. We'll leave it like that. Next slide, Sean. Okay, the diff is where we're going to count 5 different basic types of blood cells. You're also going to look at the condition of those cells when they're doing the differential. So we're going to be looking at neutrophils, lymphocytes, basophils, eosinophils, and monocytes, which are the 5 basic leukocyte types. And from there, we're probably going to go on to need more information based on what it yields. For example, if we're looking at a chemotherapy patient, cancer patient, we're looking at the neutrophils, we may have to do a little formula to find out exactly what is known as the ANC, the absolute neutrophil count, which is what is used to base orders for resumption or next dose of chemo in many cases, to see when that nadir has occurred. The thing that gets focused on is the neutrophils. They're very sensitive to the nadir and to the chemotherapy. So the neutrophil fights off infections. Eosinophils relate to allergies and parasitic infections. Same for basophils. Lymphocytes often indicate viral infections, and monocytes, severe infections by way of phagocytosis. In other words, when you get a really bad rip-roaring infection, the monocytes go up and they eat a lot of the little microbial agents that may be causing you sick, hence the phagocytosis. Okay, next, Sean. Okay, so out here to the left, we got the basic panel, basic metabolic panel, and the comprehensive metabolic panel. So I think the next Sean demonstrates next slide, Sean. Okay, so the basic metabolic panel is just something else is used to for the physician to gauge the overall health of the patient, and as bits of the puzzle to put together for diagnoses and treatment. So these lab values are going to be used to check out kidney function. Let's see, look at the next slides, Sean. I'm having a senior moment. Anyway, they're going to look at kidney function, liver function, glucose, A1C, I believe, is included in that. Pardon me. Potassium, sodium, chloride, bicarbonate, anion gap, BUN, creatinine, calcium, and glucose. So the glucose may tell us how well the pancreas is working, what the insulin is coming out like, or what effect the corticosteroids that the patient is having on their glucose level, or the infection that may be having on their glucose level if they've got diabetes. The calcium gives us a lot of information about bone disorders if they exist, malnutrition, maybe something like parathyroid involvement. The anion gap, I'm going to kind of skip. That has to do with positive and negative blood products or molecules, and what it kind of gets to is acidity. So when you look at that anion gap, if there are more negative ions than there are positive, you're going to get a negatively charged blood and or acidosis that goes with it. The bicarb, that's useful in determining kidney function, as well as perhaps oxygenation. Sometimes bicarb is used in conjunction with the arterial blood gases to gauge whether or not the hypoxia or pH imbalance is being compensated or not. Sodium, sodium is involved in everything. It may tell us everything from dietary intake, hydration status, to something like a syndrome of inappropriate antidiuretic hormone or aldosterone deficiency. What am I trying to say, rather? Adrenal insufficiency, pardon me. So the potassium tells us a whole lot. I focus on the potassium for a variety of reasons, but the potassium tells us a lot about diet. It may either tell us a lot about cardiac function or give us an idea about how it may affect cardiac function. It may give us an idea about nausea, vomiting, diarrhea, the extent and severity of it. It's a very useful tool. It's also a pretty sensitive lab test given its relative simplicity. And the reason that I point that out over and over again is every time I looked at something about a potassium, it reminded nurses and clinicians over and over again to handle the specimen carefully. And if you have an unexpectedly high potassium level, to look at the trend and redraw. If you've been running a potassium, patient's been running a potassium of 4.5 for 3 days in the hospital, and on the 4th day you check the lab and the potassium is say 6 or 7 or 8, something pretty high, pretty, pretty dangerous, really, actually, to the patient. You want to look at that, run that sample again. You don't want just to presume that that's an accurate level and start ordering treatments on a given K-exalate or something like that, only to find out later on, well, the potassium wasn't really high. It was just hemolyzed. It happens all the time. I've experienced it myself more than once. So, when we're working with these labs, there's some very important things to know first and foremost. First of all, know your patient. I mean, it seems pretty self-evident, but when it comes to labs, it's a little easier to get kind of what I call tunnel blindness a little bit or something, and get to focus on those numbers. But if you don't know your patient well, first of all, you're not going to know what the presentation was that relates to the labs that you're looking at. You may not know that, for example, if you don't get a history and look at the patient, doctor may order potassium and it may not need to be done, or it may not make sense, or the doctor may have failed to order a potassium or whatever level, only to realize later on that, we just didn't catch it because we missed something about the patient's condition or their subjective complaints. So most blood errors, like I said earlier, occur pre and post analysis. Know your patient, know the clinical presentation, know their name, know that they've got a wristband on. If you have guide, if you see in the little picture to the top left, put the little scanner, the newer scanners on there to help you identify a patient. So far, it looks like they're doing a lot to reduce lab errors by way of getting the right patient for the right test and the right tube. When you see a lab order, take a minute and think about it. If you're the nurse, if you're a clinician working with a patient and the doctor writes a lab order, before you go and draw it and send it, while you're doing all your other stuff, checking the order, checking the patient, put it in the system, all those things, getting your tubes selected, calling the venipunctures, however that works in your facility. Take a moment and just think about the orders at hand and just ask yourself, does this make sense? I mean, because it wouldn't be the first time, I'm sure, if you've been in the field for long, that a doctor would order something that really didn't make sense, or maybe it was supposed to be an order on another patient. So that's one thing I suggest when it's kind of like a medication. Take a minute and think it through before you do it. Know your institution's policies related to specimen collection and proper handling. That varies from institution to institution. Educate your patient on the test to be performed and how the sample will be collected. That gets back to what somebody mentioned earlier. Educating your patients will reduce their anxiety, make it easier for you to get your job done, reduce your anxiety because it's easier to work with them, and they're more likely to retain whatever information that you're providing in the way of education if they're not anxious. So follow policy for proper handling of specimen. Over and over and over again, I bumped into that. So if you hear me repeat it, it's because I bumped into it over and over. So I wanted to emphasize that. And I'm going to come back and talk a little bit more about what that means specifically soon. When you draw lab, something that, nurses should know this, you always want to reassess. You draw the lab, send it, report it to the physician promptly, maybe more quickly than sometimes than others, depending on how abnormal the value is and the patient's situation and the policy's procedure for the institution's procedure for reporting those labs. But, be sure and follow up. Did the labs get reported? What did the doctor order when the labs were reported? If the potassium level was low and the doctor ordered potassium, was it IV? Was it PO? Was it done? Was it given? Did the pharmacy deliver it? When do we need to recheck a lab? Those are follow-up assessment questions that really need to be on our mind from the time we get the order. Thank you, Sean. Next. So here's your basic metabolic profile, BMP. And if you're old school like me, I worked in a lab as a venipuncturist when I was in school, in nursing school. That's about 80 years ago. We called, for example, some things have changed. I did find some of these references, but we would refer to a basic metabolic panel as a Chem 6. And then sometimes we get a Chem 7, a chemistry, which would be a basic metabolic profile or a renal profile with a blood sugar added onto it. So things have changed. We're using panels to describe them now. And they have different tests than what they once did. Okay, Sean, next. Okay, so with the BMP, with the CMP rather, the complete or comprehensive, put complete, I've seen it used both ways, found it used both ways. It's actually comprehensive in most of the literature. Comprehensive metabolic panel includes the BMP plus the addition of the total protein, albumin, aspartate, aminotransferase, alkaline phosphatase, alanine aminotransferase, and bilirubin. These things, next slide, Sean. These things give us different, more information about things such as nutritional status, immune status, hydration status, liver function, kidney function. So that's the reason that these additional these labs are added on to the BMP so that the doctor can use all those in his calculations. Okay, I'm gonna focus on potassium, and item number one is critical that all lab specimens are collected and handled properly. And I have seen this, I have seen a lab tech live and in the flesh draw a tiger top tube or a serum separator or whatever that lab and facility wanted at the time, and then take the tube and shake it, not invert it, because we got this inversion that the nurses do or that you're supposed to use. But I'm talking about taking it and shaking it. Well, if you shake a specimen hard enough, guess what? Pop, go the red cells, and then your potassium is all out of whack. Let's see, transported properly. Some things require refrigeration for transport, or may need to be taken out of it, separated from the tubes at hand, and put into other tubes for transport. If they're not transported at the right temperature or with the right ingredients, for example, the preservative and the anticoagulant, then the specimen may arrive to the lab useless. So also you want to check that the treatment ordered and provided is provided to address problems that you find in these abnormal labs. Okay, Sean, next. We're always going to assess response to treatment after we do all that every time. So details matter right down to the tube top color and the order in which the specimens are drawn. This seems pretty basic, but as nurses, we may be involved in actually drawing those specimens, and knowing which tube to put the specimen in has everything to do with the value of the usefulness of the specimen when it gets to the lab. Something like, for example, there is more than one kind of tube that serum tests can be drawn in. So a specialized tube may be needed for one serum test, and a serum separator may be needed for another one. A CBC, always going to have an anticoagulant and a preservative. The clotting studies are going to be the purple tube. CBCs are almost always still the purple tube, as it has been forever. Clotting studies are almost always going to go in the blue tube, and we probably want to draw perhaps there's a little difference in what you read out there, but you may want to draw the blood cultures first and then fill the blue tube. The blue tube's almost always going to be one of the first things you do, because you have to have a full tube or nearly full tube to even be able to run that test and get a valid result. So, if you're scared that you're not going to get enough blood, make sure you get that blue tube early on. And then the reason you would do the cultures first is so you would have less likelihood of contamination when you draw the cultures. And I think in your facility, your institution will probably have a policy about which sequence in which to draw the labs or to take the specimen rather in which tube. So you might want to check with your own lab about that. Generally, most of the time it's a blue top, gray top, cultures before or after, and then you get into things like the metabolic profile. All right, thanks, Sean. So potassium levels are ordered all the time in acute care settings. And they can be run separately as part of the BMP. So what you may see is the BMP run initially, from which we get a lot of information. Perhaps the potassium is abnormal and we give a treatment to either lower it or raise it. And then we've got to come back and draw it again and make sure that we've got it right. And when we draw it again, we may not draw it as part of a panel. We may just draw that one value, that one test separately. We may not need all that other stuff. So why chalk up to just follow the potassium? So why chalk up a charge and put the patient through it if we don't have to have it? One of the reasons that we draw so many BMPs in our country, and particularly the potassium, is because cardiovascular disease is rampant in the country. I think it's back to the number one cause of death again. I don't know, it's cancer and COVID and cardiovascular disease played a little game of catch up for about 2 or 3 years there, but it's the most common cause of death in the United States, and the hospitals and doctors' offices are full of it. So you're going to be drawing potassiums all the time. So potassiums are also used to assess nutrition and hydration status. Next, Sean, please. For example, if we have a patient who has a low potassium level, it may indicate to us that maybe they're having some vomiting, nausea, diarrhea. Maybe they're taking loop diuretics that are not potassium sparing and just wasting their potassium away. Maybe they drink a little bit too much. Maybe they have an insufficient dietary intake of potassium. I intentionally use a little K plus here. I don't know if y'all see that much in the clinical world these days. I would imagine you do, but when I think of potassium and my charting documentation over the years, I think of seeing this K plus pretty frequently as an indicator, as a short way to say potassium. If the blood, let's go back to that other one first, Sean. Nope, there you go, thank you. If blood level is high, then we're thinking about, okay, are there BP meds or particularly beta blockers or ACE inhibitors or angiotensin receptor 2 blockers that may cause the potassium to go up. So, there's an upside to that, and that is that those very same loop diuretics that make the potassium go down can be given to treat hyperkalemia. So there's kind of an upside in that. On the other hand, if we want to keep this potassium on board, we don't want to use a loop diuretic, so we may use a potassium sparing diuretic like a thiazide, in which case we've got to watch the sodium to watch it go up and down, because it's going to affect the sodium level. The HTZs, HCTZs, the thiazides of the world, they take sodium right out with them with the urine. So if you switch from one diuretic to another, one type to another, you may just need to look at sodium as opposed to potassium as a primary indicator. Also, high potassium can indicate chronic kidney disease, acute renal failure. You see patients with dialysis, their potassiums are often astronomical. And, if you saw that pre-dialysis patient's potassium level and how high it was, and it was another patient that wasn't on dialysis, you would probably take quick action. In the case of a dialysis patient, the doctor probably knows about it, and it's probably part of the dialysis process. Another thing that I think is important to know is that severe, or just we talked about RBC destruction affecting the specimen. If we have a patient who has an injury or a burn, or maybe sometimes sickle cell patients kind of fit in this zone. If you've got patients that have those problems, the potassium is going to need to be monitored, because it's going to go up in the face of those problems. Also looks at adrenal insufficiency. and may have syndrome of inappropriate antidiuretic. Syndrome of inappropriate diuresis. I can't find the word right now. It also is reflected in the potassium level. Okay, thanks, Sean. Next. So the treatment for a low potassium may be something as simple as, if it's a mild low potassium, there's not a bunch of symptoms associated with, maybe something as simple as increasing dietary intake of potassium. That's easy if you eat fruits and vegetables and drink fruit juices, nuts, legumes, fish, that kind of thing. Is plenty available. So if you have somebody that's just not getting enough from a dietary way, if they can increase their dietary intake, the potassium level will come up. If it's low, we want to discontinue the loop diuretics. Probably if it's low enough, because a really low potassium, as just as a high potassium, can have pretty scary implications, such as causing cardiac dysrhythmias. So if we see a patient's got a really low potassium, especially in acute care settings, we may give the potassium IV. It's important when you do that to know that you've got to give it slowly and sufficiently diluted not to cause pain and inflammation at the site. You've also got to give it slowly and diluted sufficiently so that you don't have a cardiac problem with it. I have personally seen a big load of potassium being given and a patient go into VTAC. And the thought was that the potassium infusion had something to do with triggering it. So when we get to hyperkalemia, that's a little different. It's a little harder to treat, and we may start with including loop diuretics, maybe some IV fluids for hydration, and if it's bad enough and persists long enough, we may go to using something like K-exhalate enemas, which will basically lower the potassium by way of drawing it out through diarrhea and sometimes nausea and vomiting. Okay, Sean, next. Okay, let's talk about the lipid panel. Why is it drawn so often? Well, it goes back to the thing I was talking about earlier about cardiovascular disease in America. It's everywhere. And these lipid levels give the doctor an idea about what may be driving risk for heart attack or other cardiovascular events. So the next slide, please, Sean. So what is measured in a cholesterol panel is the LDL, also known as the low density lipoprotein. Sorry about that, I had trouble getting that. Or the bad cholesterol, and the HDL, or the high density lipoprotein, is the good cholesterol. It's been pretty well evidenced that the bad cholesterol, if it's high, it makes plaques more likely to happen in the vessels. The good cholesterol, the HDL, tends to make it more slippery. In other words, things don't stick as much if there's a sufficient volume of the HDL. And the interesting thing about the high density lipoprotein is we want more of it as a rule, but it is one that moves almost exclusively only when exercise, activity, and diet are altered. So far, there's not much in the way of a good medication to affect specifically the HDL. The triglycerides, this is pretty much going to show, how much are you building up in terms of sugars in the blood system. They're going to turn into fat, which are then going to increase your risk once again for cardiac problems. The total cholesterol is the sum of the LDL and the HDL, and it is used as a general guide for risk identification and treatment for cardiac disease. I put a note in here too that for lipid panels, some facilities, institutions, labs require a 9 to 12 hour period of being MPO. Doctors may want it that way, and some do not. So when you're educating your patients, it's important to know what that doctor and that facility wants in the way of fasting time before the test is taken. They may not want any. They may want 12 hours with just water only. Next, Sean. Okay, when it comes to comes to total cholesterol, the general principle is the lower the better. The lower we can drive that total number down, the better. So if it's below 200, we're in the right range. We're on the right track. If it's 200 to 239, well, we're entering the risk zone. At 240 and above, it's high, and we are at risk for cardiovascular disease. There are some guidelines out there. I don't think I include them in this presentation because there's plenty to include otherwise, but there are guidelines out there that you can find that indicate treatments and doctor recommendations based on a total cholesterol from 240 all the way down to the 60s or 70s, which is a goal for those who are at extreme risk or have already had heart attacks and that kind of thing. Next, thank you, Sean. So the LDL, the bad cholesterol, should be below 70. Now it does respond to medications, statins, etc. So you see where there's the ranges are listed that the doctors are going to start looking at treating more aggressively with medications, the higher the value is on the LDL. Next, Sean. So the HDL, like I said, the more the better. And if you can get it above 60, that's the best thing to do. If you get it below 40 as a female, or 50 as 40 as a male or 50 as a female, you're kind of getting into the danger zone of high risk for cardiac events. All right, next. Triglycerides below 150 is desirable. 150 to 199 is a borderline high, and at 200 to 499, we're in the high zone. 500 and above is very high on the triglycerides. So the thyroid panel is also something that's repeated quite often in the United States, and that is largely because we have a high incidence of hypothyroidism, primarily in the female population. Men get it too, but it's more prevalent amongst females. So when doctors are treating hypothyroidism, they need to see what the levels are, whether the medication is being effective, if the levels are holding or the dosage needs to be adjusted for the levothyroxine. So that's probably the most common reason that the thyroid panel is drawn. It also looks at some other things like thyroxine, free T4, I'm not even going to try to say that one, T3, and free T3. That all give us indications of things having to do with thyroid function, maybe parathyroid function. For example, calcitonin is something that we may look at, and it may actually indicate rare parathyroid disease. Okay, next, Sean. So other tests to go along with it, the doctor may want to test the thyroid antibodies to see if there's an autoimmune response going on with the thyroid. Calcitonin, used to diagnose C-cell hyperplasia and medullary thyroid cancer. They don't happen very often, but they do happen, and they're bad news when they do. The thyroglobulin is used to diagnose thyroiditis or thyroid inflammation and to monitor during treatment of thyroid cancer. Thanks, Sean. Next. Oh, I've already beat that dead horse. Let's go on to the next thing. Thank you. Okay. One of the other most commonly drawn labs in the United States is the glycosylated hemoglobin test, also known as the A1C. This particular test has made a huge impact in how we treat patients. It gives us so much information about what the blood sugar levels have been between doctor visits or between trips to the hospital, as opposed to whatever reading we get that day, and even more unreliably, sometimes whatever the patient's reporting that they're eating and what their blood sugars are running along the way. Hemoglobin is part of the red blood cell, so it also, it collects, it lives and dies. The A1C kind of lives and dies with the life cycle of the RBCs. And also the glucose in your blood causes it to stick. The more blood, the more sticky the more the A1C collects and gives us a higher reading. That's how we know that the sugar's been running high between times for us to check it. The A1C can stay stable for about 3 months, which is about how long the average red cell lives. Next, Sean. It's used to diagnose diabetes and to guide treatment and response to treatment and compliance. If your patient tells you that they've been running a blood sugar of 90 and eating nothing but protein and fresh vegetables, and you come in and they've got an astronomical A1C, you know they're not being truthful with you. All right. So in summary, I think what I wanted to get to with this is to get any kind of a greater understanding and improvement in practice and reduction of anxiety by way of just having a better idea about some very specific things having to do with understanding and drawing labs. You can't understand the lab that you draw that doesn't get run because the specimen was handled correctly. So that's why I threw that in there. It's a, with pre and post analysis errors being the number one pre and post errors when it comes to analysis being the most common errors when it comes to blood. I wanted to get that in there for sure. All right. Next. All right. Questions, answers, suggestions.
Well, CW, we're at 7 minutes after, so someone may have a question and they're welcome to place it into the chat room. But given our hope and pledge to keep you only an hour for lunch, we're going to read out one more time and post one more time into the chat room the evaluation link, which is https://www.surveymonkey.com/r/ all uppercase letters, number 2, H as in Harry, L, F as in Francine, P as in Polly, S as in Sam, the number 2. Again, https://www.surveymonkey.com/lowercase r/2HLFPS2. The password is CBC, all caps, space, Elvis, capital E, CBC Elvis. The Elvis and blood test, this is what, or at least one of the things we want you to come away with from this presentation. And I agree with Sharon Chestnut, CW. This was great information. It was well organized. And I think what she says, she'd like to hear more. I would too. First, I've got to put the top of my head back on because it's blown my mind what I've learned today. So I'm overwhelmed and overjoyed and most appreciative to you, CW, and to those of you who remain on the line. Thank you for all that you do. And let's look forward to seeing each other again on May 8th, when Dr. Rebecca Sipma of the UAB Neurology Department will discuss with us Lewy body dementia. Thank you so much, everyone. Thank you, Ms. Puckett, Mr. Bryan, CW. Have a great weekend.